Slightly different change in venue now if we looked at going down to the pedal arch, and now we're going to be talking about thoracoabdominal aneurysms. So slightly different here. These are my disclosures. The prevalence of aortic aneurysms in the United States is grossly underdiagnosed. We can look at one of the recent studies showing basically the actual prevalence is about 4.5% in men, and men over 60 years of age, it goes up to about 5%, giving over a 1.1 million instance of prevalence of the aneurysm itself. Those actually diagnosed is about 10% of that at 172,000, and those actually treated about 69,000. On those treated with EVAR is 22,000. That number obviously is becoming much greater. So we're seeing that still it's a little understood or acknowledged problem. Some of the early treatments was simple ligation of the aneurysm, and then going in, and when that didn't work, saying would wire it, trying to induce it to slowly thrombose. Obviously that didn't work very well, so then they subjected it to electrical current, trying to denature the protein and try and cause a slow thrombosis. That too didn't work. The next thought was then is let's wrap it externally so it can expand and try and prevent rupture. As many of you know, that didn't work real well and actually resulted in the death of Einstein when he had his aneurysm wrapped. When he then became symptomatic, he said he wanted no more therapy and he died of a ruptured aneurysm. Excision and grafting, exclusion and bypass, laparoscopic repair. Everything's better with a laparoscope. Need to use a robot now too, but that's certainly something we considered. Endovascular repair is probably the gold standard. We look at repair of especially straightforward aneurysms. And then the deep branching procedures, which we use as a conjunction with EVAR, and then surgical deep branching as hybrid procedures, and then going to snorkels, chimneys, sandwiches, and then fenestrated branch grafts, which will be the major component of this talk. The open repairs, good old-fashioned open surgery of making a midline or retroperitoneal incision, replacing the aneurysm with an aortic graft. That allowed us to visualize the proximal and distal extent of the aneurysm, and then reimplant a graft to take the pressure so it's no longer perfusing the aneurysm sac itself. We've studied that and compared actually endovascular and open repair. And this is a study we did through the Medicare database, comparing endo and open. And this is also was originally also put forward by the Boston group and Mark Schermerhorn. And what we found is the postoperative complications by far were greater with open repair than with endovascular repair showed here. Only the major complication of device malfunction was the greater in the endovascular group compared to the open group within the Medicare group. We then looked at propensity matched patients and really saw that there was a survival benefit in those patients that underwent endovascular repair compared to open repair. And in this matched group, it actually carried out to over 3 years before the lines became together and no longer were significant. Repair of thoracoabdominal and thoracic aneurysm is an open technique is maximally invasive surgery. Significant blood loss associated, higher acute mortality and morbidity, and higher incidence of pulmonary and renal dysfunction. Here's an example of maximally invasive surgery. The chest and abdomen are open. We're actually going in. This is a patient that had a dissection that became aneurysmal and actually had the dissection flap ball valving over the origin of the celiac and SMA. And not only did he have an aneurysm, but he also had mesenteric ischemia from that. This was done many years ago, and it was a standard open repair. And you can see, obviously, with the exposure, it becomes a fairly significant operation. And this patient, I remember to this day, came back and kind of said, well, after 6 months, he stopped hating me for the pain he had to do from recovering from this type of operation. His aneurysm was fixed, and he was able to eat, but still had a lot of recovery time. So now the alternatives I mentioned already, fenestrated branch, snorkel, sandwiches, and debranching procedures. The fenestrated graft is now FDA approved, and this is the video sponsored or supplied by Cook. And basically it means you need to have a 4mm neck below the level of the renal arteries, up to 32mm outer diameter of the aneurysm neck. And you can see here the graft is deployed, but it's partially constrained. It's deployed down, giving the first modular component here. And then you come from below, and we actually go through that graft and go through fenestrations or holes in the graft to then cannulate the renal vessels, placing sheaths in those vessels that are now being, at least the position controlled with the sheaths, deploy the top cap, deploy the graft, and then we'll actually go in and stent into those, through those holes or fenestrations to maintain perfusion to the renal vessels, SMA when required, or celiac, but now able to land in the more normal section of the aorta, giving a better chance for a long-term seal. And here you can see the balloons are being inflated, and the stents and stent grafts that we have going in there actually sealing into the renal arteries in this case, and also through a riveting type technique sealing at the interface with the actual graft itself. So this dramatically changed how we manage those patients with complex aneurysm involving up to the level of the renal vessels. This is now FDA approved, and when we talk about fenestrations, we're talking about 3 major variants. On the far left in the screen, you'll see a scallop. You'll see a large fenestration, which generally has struts involved, and a smaller fenestration, generally 6 by 6 or 6 by 8 millimeters in size. And we can actually have those custom made for us, so we then line those up very precisely with the aneurysm itself. Here's one of the first cases I actually participated in. It was in Barcelona, Spain, back in 2003. And we were able to come in, and here's an aneurysm that extended right up to the renal vessels. And then we came in and placed stents and into the visceral vessels, as you see here, the renals here, and then balloons deploying the graft, and then we're able to get a complete seal. We've now done hundreds of these type of cases with excellent results, and I think it's dramatically changing how we're treating these patients compared to standard open repair. There are times when we've had to modify graft. I've done this over 200 times, where we actually had to make custom grafts for patients coming in with either branches or fenestrations on the back table. So the patient would come in symptomatic, we'll show in a minute, and then we actually created the graft on the back table, repackaged it, and reimplanted it. This now needs to be done under a specific IDE, which makes it a little bit more challenging. Here is again the graft being reloaded into the graft. Into the sheath delivery system. We had an 83-year-old woman as a Jehovah's Witness that presented to us with a symptomatic thoracoabdominal aneurysm. She categorically refused any blood transfusion. She was originally diagnosed in 2007, and she made the rounds through the northeast corridor of trying to find a physician that would actually fix her thoracoabdominal aneurysm. She went as far as Boston to a little-known hospital called Mass General, and they told her to get her affairs in order. She was not a surgical candidate, and there's nothing more that could be done. She accepted that until she started having severe abdominal pain. She was seen by one of our colleagues, Dr. Herb Dardick, over in New Jersey, and he referred her to us with a contained rupture of her thoracoabdominal aneurysm. She had multiple medical problems, including anemia, arterial occlusive disease, COPD, and most importantly, her complete refusal for any blood transfusion and chronic renal insufficiency. Here's a 3D reconstruction showing her thoracoabdominal aneurysm, and again the angiograms showing the very diverse nature of her aneurysm involving above the celiac SMA and down into the iliac branch vessels. We created a 3-vessel fenestration. Her celiac was occluded proximally, and we're actually able to build a graft for her with branches going to the celiac and renal vessels. Excuse me, the SMA and renal vessels, and actually then built proximally and distally, completely excluding her ruptured thoracoabdominal aneurysm. She actually was able to walk out of the hospital in about 4 days and has continued to do well, never receiving a blood transfusion. So I think this is again showing what can be done with these patients with these very significant problems. We're now considering other actions, which is called parallel grafts, which you can then place standard grafts in and do this without having to have a custom graft performed, and this is something we're doing more routinely. This is a quick video showing a pivot graft, which is now off the shelf under clinical trials for treatment of suprarenal aneurysms going up to the level of the SMA. We found through study that there's more standardized physicians have used the SMA as your central point for the position of the renal vessels, and hence we created a graft that has ready-made pivots on them, as you can see here, that allow flexibility both anterior, posteriorly, and superiorly and inferiorly for positioning, as you can see. Here's the delivery system itself, but it does allow us to go in and have a off-the-shelf alternative to treat these patients. We'll go through this fairly quickly. Here's the juxtarenal and suprarenal aneurysm that's being treated. Again, you can see the involvement of the renal arteries within the aneurysm itself. Here's the P-branch graft coming up. and we partially deploy it. Again, it has the same restraining sutures as we saw in the other grafts. And then we work through pre-wired fenestrations and going out to catheterize the visceral vessels through these pivot grafts. And then here's where the fenestration is for the SMA. With that, we're able to catheterize all the vital vessels, put stents in there, and then perfuse, as you've seen in the earlier study. So this is a generalized overview of the fenestrated graft and with pivots. And then finally, I'd like to show one other type of graft that's coming forward, and this is the TAAA branch graft, which has both a retrograde and antegrade configuration. As you see here is antegrade and retrograde, and this allows us to treat type 4 thoracoabdominals. The Mount Sinai system is one of the 6 systems that actually had the opportunity to implant this graft. We were one of the first in the Northeast to do it, and here's the example of the implantation. Oops. Going back, showing that a very complex aneurysm, which we were able to, through crossing limbs, able to treat that in its entirely without the requirement of open surgery. So I think certainly the future we're seeing for complex aortic aneurysms is getting brighter and brighter, and we're going to be able to manage more and more of these patients in minimally invasive ways and not have to have the morbidity of standard open surgery. Thank you very much for your attention.